So I'd like to welcome everybody to the Northwest London webinar on lower GI cancer, hosted by Royal Marsden and Partners West London Cancer Alliance. My name's Bushra Khajawa. I'm the lead GP for cancer in Hillingdon. I'm very pleased to have with me today Alistair Myers, consultant colorectal surgeon, speciality lead for general surgery and urology at Hillingdon and Mount Vernon Hospitals, and also chair of the colorectal cancer working group at Royal Marsden and Partners. Next slide, please. So just some housekeeping. We would like to keep this session as interactive as possible, so please do use the chat function for your comments and questions. Also, it would be great if everybody could keep their cameras and microphones off. We are recording this session, so that will be distributed via the training hub, and also the primary care communications team will also be sharing the slides as well. Next slide, please. So the main aim of the session today is to support early detection of lower GI cancer in primary care. We all know that picking up cancer early is beneficial for our patients as it improves prognosis and outcomes. So with this in mind, we'll be looking at the 2-week wait referral pathway to ensure a prompt diagnosis and treatment of cancer. And I think it will be useful to look over the pathway as there have been significant changes, particularly with the introduction of the FIT test. We'll then go on to talk about the bowel cancer screening program and the support available for practices to increase uptake. And of course, screening is a great way to increase picking up cancer earlier. And lastly, we'll be signposting you to resources available to support you and your patients. Next slide, please. So the agenda for today, I'll start off by looking at some of the data for 2-week wait referrals in Northwest London. I will then hand over to Alistair for the 2-week wait referral pathway, including a little bit about the role of advice and guidance and some interactive cases. And then I'll finish off by going back to bowel cancer screening. The aim is for the session to run for about an hour, finishing at 2 o'clock. Next slide, please. So why are we talking about lower GI cancer? There are 42,900 cases each year in the UK, so that's 122 new diagnoses every day. It's the 4th commonest cancer in the UK. Most cases are in older patients, so 9 out of 10 cases we will see in over 50s. However, it is important to be vigilant in younger patients, as over 2,500 cases are in the under 50s every year. It is slightly more common in men and also in our more deprived sections of the population. It is also seen more commonly in people with white ethnicity as opposed to Asian and Black background. Next slide, please. So this slide is looking at the 2-week wait referrals for Northwest London and breaches. Now, breaches refers to patients who are not seen within the target of 2 weeks or 14 days. The data has been split up per trust, and as we can see, 3 trusts have met the target and 3 haven't. So that means overall performance for Northwest London in November 21 is 87%. So we have missed the target, which is 93%. So we've missed the target by 6% in that month. Next slide, please. So this slide is looking at referrals to the 2-week wait pathway in Northwest London between April 2019 to November 2021. So looking first at the purple line, so for referrals in 2020-21, we can see there was a significant dip. Now, this is probably a combination of the pandemic as well as introduction of FIT testing. And then if we look at the most current line, so that's the pink line for 2021-22, we can see there has been an increase in referrals and recovery is pretty much back to 2019-2020 levels. The table at the bottom looks at the data broken down in trust. And there is differing recovery in different trusts, and we're not exactly sure why this is. One of the reasons could be redirection of 2-week wait referrals to certain trusts to allow for COVID work. Next slide, please. So the faster diagnosis standard is an NHS England initiative. It's there so that patients, when referred on the 2-week wait pathway, should receive a diagnosis or be told whether they have cancer or not within 28 days. The target is 75% of patients should receive their diagnosis within 28 days. So that's the red dotted line. As we can see from the actual activity, so the pink line in Northwest London, we are consistently below this target. Next slide, please. So this graph breaks it down even further. So the grey sections of the graph are looking at the patients who are waiting the longest. So the grey section is those who are waiting 43 days or more. So just looking at the latest bar, so November 21, that's 29% of patients waiting from referral to finding out whether they have cancer or not for more than 43 days. Next slide, please. So this is a summary of November 21. And so all patients referred via the 2-week wait referral pathway on the lower GI pathway picked up 35 cases of cancer. 29 of those were lower GI. Other cancers were picked up via the lower GI pathway. So 4 upper GI were picked up, 2 gynecological cancers. And out of these 35 patients who received a diagnosis of cancer, 21 patients had to wait longer than 28 days to be notified. Now, this is a combination of the volume of referrals as well as capacity in secondary care. And there's clearly a mismatch, and we can talk more about that as we go along. Next slide, please. So this slide is discussing first cancer treatments. So first cancer treatments is a surrogate marker of new cancer diagnosis. And what it's showing us is about half of cancer diagnoses come through other pathways, not on the 2-week wait pathway. So that would include other specialities, consultant upgrades, and also the bowel screening program. Of significance is looking at the screening line. So we can see that there has been an increase over time of cancers being picked up by screening, which is really good news because this means picking up cancers earlier, which gives patients a better chance of survival and a better prognosis. Next slide, please. Okay, I'm now going to hand over to Alistair to talk about 2-week wait referral pathway and to go on to cases as well. Thank you, Alistair.
Hi, thanks, Bushra. As Bushra says at the very beginning, if you can diagnose cancer early, you can improve outcomes. This, of course, isn't the whole truth, as we all know. There are cancers like thyroid cancers, which are so indolent nobody quite knows what to do with. There are the suspicion is that lots of breast cancer, it's already decided in the genes what the outcome is going to be. But if it is true that early diagnosis saves lives, it is true in these solid organ adenocarcinomas. We know and have known for decades that if we take away polyps, the population which are screened for polyps at precancerous state will die less often of colorectal cancer. This is, proven. So it's all about early diagnosis. And it's quite interesting that post-pandemic, we're starting to pick up more through the screening route. That had been falling off for about a decade, and nobody quite knows why. But I don't want any of you to think that we blame primary care for the lack of early diagnosis. This isn't what's going on. The prevalence of GI symptoms is enormous, and the accuracy of GI symptoms in terms of diagnosis is really poor. So we had FOB, and then we suddenly had FIT, and FIT makes a difference. FIT allows us to triage, even in the presence of rectal bleeding, as reported by a patient. FIT allows us to guess how likely or not somebody is to have rectal cancer, to have colorectal cancer. We'll discuss this in a bit more detail in a second. This is the current form. These forms do get updated about yearly, and they do sometimes look very similar. So I guess the first thing to say is just make sure you're using the most up-to-date form. My screen's gone a bit funny. I've got a really funny looking slide with loads of blurriness. Is everybody else seeing that, or is it just my computer?
No, we're all getting that, unfortunately, Alistair. Yeah, it does tend to clear.
Yeah, okay. So the next slide, please. It hasn't moved. Yeah, so what happened was we've done, as a nation, we've done lots of studies on fit, and in this part of the world we did nice fit, and we took about 11,000 patients in whom a GP had already asked for a 2-week referral, and we asked them to have fit, and we looked at the results, and we came up with 2 headline figures, and these are important to remember, and they're both true, and I'll explain why. So if your background 2-week wait referral was roughly 3% of 2-week wait referrals would turn out to bowel cancer beforehand. What we now see is a negative fit in this population, meaning less than 6, for want of a better term. Negative fit meant you had a 99.7% chance of not having bowel cancer. So the negative predictive value was incredibly high. That said, in the region of 10% of people with bowel cancer will have a negative fit. So those 2 statements are both true, but one sounds good and one sounds bad, and it's because you're basically picking up 90%. If you use fit plus your clinical judgment, you're picking up about 90% of cases. So 3 in 100 risk becomes a 3 in 1,000 risk. So for the patient in front of you with symptoms who has a negative fit, you've got statistically about a 3 in 1,000 risk of them having bowel cancer. Now, of course, they might have a significant polyp or something else that really needs to be dealt with, or they might turn out to inflammatory bowel disease, or they might turn out to have some other important process. But fit is not particularly good at excluding significant polyps or IBD, but it is particularly good at colorectal cancer. We'd done all this work, we'd proven it, and in Croydon we were in the process of, or my colleague Muti Abdullah was in the process of introducing fit into the 2-week wait pathway, and was going to pilot it and was going to count it all really carefully, and then COVID hit, and suddenly we have this horrendous problem whereby, in addition to everything else, we have to shut endoscopy services because we don't know the risk of COVID transmission in endoscopy. We don't know how many doctors and nurses we might kill with taking COVID positive patients into endoscopy. And I don't know if you all remember, there was that theory that you could get viable virus in feces at the beginning, and the mortality rate amongst particularly surgeons in Italy in March 20 was really worrying. And so we shut for about 8 weeks. In the middle of this, we collectively mandated the use of fit. We said, we've got this tool, we don't have time to study it properly, we need to just get on with it. And so it came into the pathway, and then we argued, and we did argue, to be honest, across London as to whether it had to be absolutely mandatory, or whether there could still be a box that said clinical concerns, tick the clinical concerns box, and we'll still see them on a 2-week basis. And the collective decision was that there should still be a clinical concern box, and so that remained on the form. Okay, next slide, please.
Alistair, we've had 2 very good questions. So the first question says, how often does fit negative miss cancer? And then I'll put the second one with it because it's related. Does fit positive predictive value change with age?
So the second one first, no, not that I'm aware of. The first one, I'd have to go back to the original data. I don't think so. The first one, how often? So it depends on the study, but in it's something in the order of 10%. So in nice fit, it was a bit lower. The Royal Free report a bit higher. Some work at UCH which says that 2 negative fits give you about a 1 in 1,000 risk of having bowel cancer if they're done something like 6 weeks apart. So yes, one in 10 people with cancer with colorectal cancer will have a negative fit. And at the same time, a patient in front of you with a negative fit, who you would be otherwise referring on a 2-8 pathway, has about a 3 in 1,000 chance of having cancer.
Thank you.
Okay. So what does that mean? Okay, so you'll get that fit's important. I think we've laboured that. So what do we do now? So this slide is what do you do practically with the patient who has symptoms and a negative fit? So we'll talk through some cases later on. And the first thing to say is that we we recognise that it's difficult, and we've had a service now since, well, before the pandemic, but got much better during the pandemic, whereby my colleague Sami Ijaz will, with her team of nurse specialists, go through all the referrals, and she does. I just saw that comment. I think that's a really important. Can we do that comment first? So go back to that last, whoever Harish Mystery is. If fit negative misses cancer, 2-8 on clinical judgment is a must. Yes, that's why we said it was still possible. But at the same time, you must recognise that if you have a patient with symptoms who has a negative fit, your clinical suspicion is based on a statistical likelihood of 3 in 1,000. So sure, if you're concerned, of course. And I guess what we're dealing with is this overlapping questions. On the one hand, there's and I've done this before at GP masterclasses, there's the question that's what's wrong with my patient on one side, and then on the other side, there's the bit about does my patient have bowel cancer? And of course, real life, you're often in the middle bit of the Venn diagram, aren't you? You're saying, I don't know there's something potentially wrong, amongst which bowel cancer might be one of the more likely diagnoses, but I need this patient seeing. So it matters to us which route they go down at this stage, because if you write a letter into us that says, I suspect colorectal cancer, then we are going to exclude colorectal cancer based on that referral. And we're going to do that with a test that might not be appropriate. They may be triaged straight to colonoscopy as perhaps the best test of finding colorectal cancer, and that may not answer your question. So if the question is not, I think this patient has bowel cancer, if the question is more general than that, then we should discuss how we might better triage those patients. So let's this came from a recommendation about redoing fit in people who remain symptomatic. And I guess what the take-home message from this slide is that we, meaning Sami Ijaz and the team, are really happy to discuss these things on the phone and work out what's going on. And triage and signpost, or whatever the right word is, and get your patient into the right setup. Go next slide, please. The straight test concept comes from this idea that if we see patients in 2-8 clinic and almost all of them got a test, did we ever need to see them? And most of us kind of took a long time to concur with this idea, because straight test in practice means that you swap 10 minutes with me for 45 minutes a telephone assessment with a straight test service, at which they're fundamentally assessing fitness for the test rather than the appropriateness of the test, or which is the best test. I mean, there is some leeway in that, but by the time you get to being a consultant colorectal surgeon, you've done an awful lot of assessment of patients, and you're pretty good at very quickly assessing and booking the best test, the test that is most likely to point to the right answer. And but in principle, the NHS prefers the idea of straight to test, prefers to think, well, if GPs assessed the patient as needing bowel cancer excluding, we should just go ahead and do that. And 90 to 95% of the time, that will be the right pathway anyway. So on the basis of that, we've gone ahead and put in place about 2 years ago this big straight to test system, and it works pretty well, I have to say. We're seeing about 220 to 250 referrals a month. And I should say we are doing about, I'd say something like 90 or more % will come in with a fit test attached to those referrals. Next slide, please. This was an audit. It was done elsewhere. It was done at London Northwest, and it looked at you know, what proportion of this 2-week referrals were going straight to test, what proportion were diverted to clinic. We'd set things up to try and get as many as possible straight to test. In fact, the faster diagnosis standard Bushra mentioned, this idea about getting everybody turned around within 28 days. The hospital that does it best in North and South West London is Kingston. And their setup has always been that they have a lot of very urgent outpatient appointments, and they still send about 40% of people to outpatients, and just have a staffing profile that allows them to do that. And by which I mean they have one consultant in particular who's incredibly committed to this, i.e. is not committed to being in the operating theatre as much, which I think is how they manage it. Next slide, please. There's obviously going to be reasons why we see people in clinic rather than straight to test, and this is a snapshot of what's going on London Northwest. There's usually something in the letter or the background, or we've seen the patient before not that long ago, and we've done a bit of investigation before, but we're coming back. And there's often a mixture of reasons why this bar chart looks is a lot of low volume of different reasons. Next slide, please. This is London Northwest data. I'm sorry, I'm seeing this for the first time now. We all have different performance figures in terms of how quickly we see people and how quickly we get to investigation and either discharge or treatment. I could talk about Hillingdon in a second. Next slide, please. Same sort of data again. Next slide, please. Patients are informed in a variety of ways, obviously, as to how they, sorry, get that out of the way. They're informed in a variety of different ways. The difficulty with this, as you'll know from having received some of this communication back, is you don't know whether you've answered the question. If this is all done remotely, so if there's a GP referral in on a form, we do a colonoscopy, we exclude bowel cancer, we tell the patient at the time they don't have bowel cancer, and we follow that up with a letter. Have we really answered the question? And sometimes it's very difficult to work it out from the referral alone. I hope that most of us at endoscopy, most of us who are doing endoscopy will be kind of picking up on the concerns that the patient has and addressing that in the free text of the endoscopy report. But a very large number of people are going to CT virtual colonoscopy. Yeah, next slide. So the alternative routes to...
So Al, just before we go on to that, we've got another question from Harish. Those taken off the 2-week wait pathway without investigation, do you ever look back to see if any cancers were missed?
Yeah, not only that, but we look back, we look back in a couple of ways. The more worrying figure actually is there's a metric called post-colonoscopy colorectal cancer rate, where we're now reporting. I mean, this is where the whole story gets very difficult when you start to go into real life stuff. There's about the national rate of people diagnosed with bowel cancer who have had whole colon imaging, CTVC or colonoscopy, said to be negative. No, sorry, not totally. Who've had a whole colon image in the preceding 3 years is about 3 to 4%. And we all audit that. So even more worrying than do we look back to see if they've had cancer diagnosed before, or do they subsequently get diagnosed with cancer, is that we know, is that we see it at the other end. So we have a tab on how many we've missed. We have a very good idea of how many we've missed at a colonoscopy or CTVC. If it's at CTVC, then yeah, it goes to radiology discrepancy meetings. And if it's endoscopy, it goes to endoscopy user group meetings. It gets DATIX by and large. And then there's the whole process of 72-hour report where we decide whether it's a serious incident, whether it's a genuine miss. I have to say at the moment, I think we've got it to all tests of a miss rate of something low. The biggest problems, the biggest repeated problem for missed diagnosis of bowel cancer that I come across is failure to recognise iron deficiency anemia and act on it at diagnosis. And I do want to come on and talk about that case specifically when we do the clinical scenarios. The alternatives to weight referral, so ideally, is advice and guidance. You write it down and you get a return. Somebody should. So advice and guidance also got crashed through in the pandemic. It sounds like a great idea, and it is to some extent. And but it definitely applies. It definitely has more use in some specialties than others, and it is a heck of a lot of work for some specialties. It seems to probably work best in haematology, in everybody's general experience, where haematology were regularly giving out advice via phone call or email regarding blood tests results. They can now do it in advice and guidance, and then it's beautifully recorded. It really does suit haematology. For gastroenterology, it is about currently running at a session a day. So 4 hours work a day is being paid for, or even not paid for properly, but that's the estimate, that you're taking out a clinic a day to just do advice and guidance 5 days a week. In general and colorectal surgery, and there's a big overlap between general and colorectal surgery, our audit data suggests it's almost useless. For us, we see 92 to 95% of, we recommend referral 92 to 95% of the time, and most of the rest of it is redirection of, to vascular surgery. If it's just been set to general surgery when it's varicose veins, it's most of the time in general surgery, advice and guidance is not particularly useful, I have to say. It's also probably worth mentioning that these services were introduced quickly without consultation, job planning, payment, and are currently being provided for free, which is fine. Next slide, please. Okay, this is data from a really good piece of work. This is about the question about rectal bleeding. This is what this is really about. And the take-home message is you should still do a FIT in the presence of rectal bleeding, because it's still effective in helping us triage. The reason for that is probably that the majority of rectal bleeding is intermittent. If they come to you with bloody diarrhea every day, you're going to refer them in, obviously. If it's, I bled heavily last week and I haven't seen anything since, then FIT is still very well worth doing. This data won a prize. In fact, it was done by one of our previous registrars, Georgina Hicks. You're welcome to peruse through it at your leisure. Next slide, please. Okay, let's talk through some realistic case studies, ignoring my surname being misspelled. Right, so typical patient, so 27-year-old lady, bright red rectal bleeding, no other symptoms, starts telling you about family history of IBS, recently turned vegetarian, trying to lose weight, trying to be fitter, doesn't look that, like she's lost that much weight to you, but she's trying to be healthy. she thinks there's always something in the history that makes you a bit wary, and she thinks, you know, she says Granddad had stomach cancer or liver cancer or something in the stomach, and they don't really know when. So what do you do? So 27-year-old bright red rectal bleeding and nothing else has an incredibly low chance of having colorectal cancer or a significant polyp or something that needs intervention. So reasonable options. This is a choosy thing, isn't it? You choose. Is that right, Bushra?
Yes, it should be, but I can't see where the option. Oh, they're just coming up. Yep. So I think let everybody.
Oh, right. Yeah. Okay. So
there we go. It's up. Everybody can put their responses in now. Okay, so the winner seems to be fit test and blood test. It's about 60% of people would do a fit test and blood test.
Yeah, so I think that's a completely reasonable option, isn't it? I mean, I think it's probably not likely to turn out to be bowel cancer. I don't think anybody down the line would criticise you for that. I think safety netting is entirely appropriate. The other option, which may come online relatively soon, is through things like RDCs and the use of, we've been trialling this device. There's a newish device around. It's like an old-fashioned rigid sigmoidoscope with a camera on it, which has a trade name. I'm not going to plug it because I'm not sure. It's a very, very beautifully designed piece of kit that we're trying to work out what it's actually useful for at the moment. But that sort of thing, it depends. I get the feeling, I don't know, because it's a very long time since I've done any primary care work, but I get the feeling there's very little proctoscopy or rigid sigmoidoscopy going on in primary care. I'm happy to be corrected or re-educated, but I think there's not a lot going on, and I don't think that's inappropriate. And I think that safety netting, and if it's carrying on for us to have a look in a routine way, is entirely appropriate. The only additional additional question I might add into that history taking is the bit about has anybody had any sort of cancer in your family at a relatively young age? So say under the age of 45, and you're thinking perhaps of Lynch syndrome and all the other things, so ovarian, endometrial, breast, or whatever. But by and large, I think doing a fit or managing, examining them, having a look, and safety netting them would seem to be the best thing, I should think. Okay, next slide, please. Right, so a slightly different middle-aged bloke who you don't know because he's very thin notes, never really comes to general practice, describes tenesmus, constantly feeling like there's something there. Every day when he has a poo, there's slimy, mucousy blood stuff. You examine him, you can't feel anything, but he's a big guy, and I don't know if you've ever measured your index finger. Mine, this is important in my world. My index finger is 8 centimeters from here to here because I need to be able to feel where cancers are. But there are big fellas that you can barely get your hand, above the anal rectal junction. He thinks somebody did something last year, but he's not 100% sure, and you've got no record. What would be a reasonable? So should we choose an option then?
Yeah. So I think there should be another poll coming up any second. Yep, just popping up now. We'll just give everyone a minute. Okay, so this is interesting. 26% of people would just 27 would, well, yeah, about a quarter would just refer on the 2-week wait pathway, and majority of the others would do a fit and blood tests.
Okay, Okay, I wrote this, and I would have referred this in, you know, doing the fit and the bloods along the way, but I would refer this in. I think tenesmus is if it's true tenesmus, I think that's an incredibly powerful sign. I think that you know, everyday slimy, mucousy, altered blood is a worry. If he's 56, he may have had a go at a flexi scope. He may have been called up by the Bowel scope program at 55, but it's an imperfect test. If he turns up with bad bowel prep, they may not have got very far up his left-hand side at all. So, well, there's no option for fit and 2-week wait. Well, 2-week wait, I think, as we've all agreed, incorporates a fit. So I think there is a 2-week wait with a fit and bloods along the way. I think is a completely reasonable thing to do in this sort of setting. Tenesmus, I should just say one word about tenesmus. Tenesmus is a different symptom to incomplete evacuation. The very common pelvic floor dysfunction problem of feeling like you haven't emptied properly, or having to go back and empty more normalish poo is more of an incomplete evacuation thing. Tenesmus is more towards the feeling of constantly there being something there constantly, which is unaffected by opening your bowels. Although I accept that these are very patient-dependent phrases. You know, you'd have to take a history very, very carefully. But in a man, tenesmus would worry me. Okay, next slide, please. Right, so another relatively elderly lady, family bring her up. Perhaps her English isn't perfect. The family says she's just not eating. She's got no energy. She's still pretty overweight, sitting there in the chair looking at you, but they're saying the weight's just dropping off her. She is anemic, but she always has been, as far as you can tell. This is incredibly common to diabetic hypertensive. I think we've all got a mental picture of this patient. So what might you do next?
So we should have another poll coming up. Okay, we'll just give everyone a minute. I think the default seems to be fit and blood tests. So
yeah, do you think we pushed that too hard? I think the issue with this is, so what do you do? So the fit comes back normal, but you're still worried. And so the reason I think in this situation going straight on the colorectal pathway is wrong is that the question is possibly not that is that colorectal cancer is a possibility, but it's by no means the only possibility. And the idea behind the split between the lower GI and the upper GI 2-8 pathway is that this kind of much more vague symptomatology, but with weight loss that you're worried about, is probably the sort of thing where we're going to do a whole body CT first as a best guess at picking up pathology, because we'll see the kidney tumor, the big mass in the abdomen, the liver mets or whatever. You know, we'll see the big stuff first. Whereas if we go straight for colonoscopy, we probably won't get it in the first go. So I think sort of fit and blood test to start with is right. So bloods to look for iron deficiency, but then you have this enormous problem that a very, very large proportion of the female Asian heritage population, certainly in my part of the world, is borderline anemic, borderline iron deficient a lot of the time. And you don't really have a background. So if you could look back at this lady's blood test, you might find it's been like this for 10 years or more, but you don't know. If it's been going on since 2019, it's probably by this stage not bowel cancer that's causing it, because it probably would have come to our attention already, but it still might be. So I think,
and also the rapid diagnostic clinic, Al, might be useful here. So if the fit was negative and you were still worried and you couldn't really find any upper GI symptoms, you might go down the route of the rapid diagnostic clinic.
Yeah. So these are the ones that, if they come to us on 288 colorectal pathways, these are the ones that we would tend to send for CT virtual colonoscopy first, as a way of saying, of excluding bowel cancer because we've been asked to exclude bowel cancer, but also of getting a scout of the abdomen. But CT virtual colonoscopy is quite a labour-intensive procedure, and there is a capacity problem with CT virtual colonoscopy. A CT abdomen, chest, abdomen, pelvis with contrast is a very quick procedure, and at the moment it's certainly easier to get. So these are difficult cases. I mean, that's why they're deliberately put up with lots of little caveats and things to think about. If it was easy, we wouldn't all be talking about this. But either way, so if we get this sort of patient in on a straight test, on a 288 pathway, we tend to straight test them to CTVC. But another way would be to do a fit, do some bloods, and if it fits negative, but you're worried, then 288 upper GI is probably the way to go. Okay, there's some questions came flying in and I didn't manage to catch them. I can find the conversation. Is this because she's foul tray? Why is she iron deficient? Why is she vegetarian? I don't know. I do know that the presence of, to the point where you actually wonder about the normal ranges for hemoglobin in West London. Microcytic anemias are incredibly common and very long term. And so I guess a change towards microcytosis anemia is more worrying than if it's been like that. As you've got thal trace, you've vegetarians at dietary, it's probably long term. But I wouldn't want to you can investigate it at leisure, I guess. What's the radiation risk of CT virtual colonoscopy and total body CT in a 78-year-old woman? Nothing. CTVC. So the term CT virtual colonoscopy, CT colon, CT pneumocolon, virtual colonoscopy are synonymous. They're sometimes different hospitals with very slightly different techniques, but what we're talking about is a CT scan where the patient doesn't have full bowel prep beforehand, but takes some oral preparation which tags the feces so they're radio opaque on the scan. The patient then comes in, has a catheter put in the anus, gas insufflation of the colon, and then in two positions, usually on the back and on the front, you run a CT scan, and the radiographers are trained to get the best possible quality images according to the position they put the patient in. You can then, it's about a 30-minute CT slot. It requires the patient to be able to get on and off a CT table, obviously, and it requires the patient to understand that it is moderately uncomfortable having all this gas forced up your anus, but it's not the we call it CT virtual colonoscopy. It's not the most virtual procedure ever, I have to be honest. It's probably as good as optical colonoscopy, as normal colonoscopy for visualizing cancers. You won't really miss cancer on it. You will miss small flat lesions down to about 5 or 6 millimeters, and you will miss anorectal lesions. So anybody coming up really needs that's why the form is designed. Somebody needs to have a look at their anus. Put a finger in the bottom and just have a feel and a look and check that you're not missing an anal or ultra low rectal cancer. Something definitely palpable, because you will miss those, because as the catheter goes into the rectum and the gas distends, you won't get anal distension. The advantages are, as well as I say, is that you get a general scout around the abdomen, so you'll pick up big things like kidney cancers, liver mets. You won't see the stomach particularly well. You will see the pancreas. You will see the kidneys. You'll see hernias. You'll see, big stuff, big anatomical problems. You'll get, but not small flat things.
Alice, sorry, can I just ask a question about this case? So
yeah.
This lady's come to see you. First of all, we want to establish, is she truly losing weight? Because the amount of times we have patients saying I'm losing weight, and when you weigh them, they're the same weight they were 6 months ago. Obviously, you want to rule out that her diabetes isn't out of control, because that would obviously make her lose weight. And then, so once we've done the fit test and that's come back negative, and your gut feeling, like I couldn't quite work out, were you trying to make out that we should be referring her regardless to like upper GI to?
Yeah, I think if at review you've got this, you're worried about significant weight loss, and you're worried that it might be cancer and it's fit negative, that should go 2-week upper GI. Yeah.
Upper GI.
And that was the guidance that came out a while ago. And we have seen, we've never quite got back to, there's a post-pandemic, there is a little bit of the work has gone to upper GI and been taken away from colorectal.
And if we're not worried, would you be happy for us to just give her some iron tablets and review her in 6 weeks? Or let's say she's not losing weight. So
I think this is your, I mean, this is your I suppose I'm not really telling you how to manage it. I'm saying what, if you want to refer her, who to refer her to. Right. I can imagine, I mean, I see, obviously, we used to, pre-pandemic, see an awful lot of patients like this who had been referred up on a 2-week wait, you know, see the patient and sort it type of way. And by and large, we did a CTVC on this sort of thing, you know, examined them. I imagine what you do, I mean, I don't want to tell you, I imagine what you do is you'd investigate the anemia as you saw fit. You might be able to get some longer history. You'd treat the anemia. And if she's never been, if it's relatively new, or if she's never been topped and tailed, then it would seem sensible to top and tail her. But if she's fit negative, you know, you're literally statistically saying 3 in 1,000 chance of having bowel cancer today. And if you do another fit, 1 in 1,000 chance of having bowel cancer today. And therefore, a 2-week wait to colonoscopy seems like the wrong test and may delay the diagnosis of something else.
And bowel cancer includes stomach cancer as well? Does it go like the whole gut, or is it?
No, I'm talking about colorectal cancer.
Colorectal, right. Thank you.
No, that's just for utter clarity. FIT has only been evaluated in the diagnosis of colorectal cancer. There is no data on stomach or small bowel or even anal. Next slide, please.
Okay, so I think it's back to me to talk a little bit about the National Bowel Cancer Screening Programme. Next slide, please. So the National Bowel Cancer Screening Programme uses the FIT test. It's offered to men and women between the ages of 60 to 74 every 2 years. Those aged 75 and over can request a kit by calling a free phone number. It's completed at home, they're given instructions how to do it, and it's looking for hidden blood in the stool. It can identify polyps, which could be predecessors to cancer, which can then be removed. So the national target for screening is to reach at least 60% of the target population. London is just below this at 59.9%. And looking at, the slide's just gone blurry, but looking at the data for the different boroughs, we are, there's a great variation in the different boroughs, so there is a lot of work to be done. The screening programme has been extended from April 21 to include 56-year-olds, and the aim by 2025 is to reach everyone between 50 and 74. Next slide, please. So Royal Marsden and Partners has procured an organisation called Community Links. This involves trained trained workers to call patients approaching their 56th and 60th birthday who have not returned their FIT test as part of the bowel screening programme. From April 2022, they will also be focusing on those approaching their 58th birthday. So these are facilitators who have been trained by the charity. They make calls from the patient's GP practices, so they are more likely to be trusted by the patient. Each patient may get up to 3 calls. The facilitators can talk through the process if the patient is worried about what the process may involve. If they've lost the kit, they can reorder them for them. And facilitators often come from the same area, are multilingual from various different cultural backgrounds. And the idea is reducing inequalities in the uptake of bowel screening, and of course, focusing on practices with the lowest uptake. Next slide, please. Again, looking at the different boroughs, a big variation in the sign up of practices in different boroughs to the Community Links programme. If you are interested and you think your practice hasn't signed up, please do contact Royal Marsden and Partners Primary Care Team to sign up. And as I said, these slides will be shared out and the link is on this slide. Next slide, please. What else can practices do to support improved screening uptake? So as Al has mentioned, lower GI cancer, when picked up early, can really make a big impact on the prognosis of patients. So when we do receive results for the screening test that the patient has not taken up the offer, we might want to think about having a system where we send out a text message straight away. Being reached out from your own practice may encourage you to take up the programme. Practices might decide to do a search on patients, maybe those who are exiting the programme. So maybe if you feel you wouldn't be able to deal with very large numbers, maybe looking at the 70 to 74 age cohort. We know from cervical cancer screening as well that GP endorsed letters make a really big difference. There are templates available through Cancer Research UK, and the link will be provided on this slide. There are also customized communication aids. So for example, easy reading literature for those with learning disability available through the NHS. And we will also be sharing that through this slide when it's shared. Next slide, please. Next slide, please. Thank you. So in summary, bowel cancer screening is for men and women aged between 50 and 74 without symptoms. And the aim is to increase this down to 50 by 2025. Please check with your practice manager or Royal Marsden and Partners Primary Care Team to see if your practice is participating with this Royal Marsden and Partners funded Community Links initiative. Increasing screening uptake also supports the PCN DES requirements. Next slide, please. So these are resources for clinicians. And next slide, please. We've also got resources for patients, and these will be available to you after the webinar. Next slide, please. So thank you very much, Alistair, for giving us your time today. It's been a really informative session to go over the 2-week wait pathway, discussing whether or not the lower GI 2-week wait pathway is the correct pathway for our patients. And we know that yourself and your colleagues are here to discuss this. And again, just going over the support available for practices to help their patients with bowel screening. So we have 5 minutes left. If anybody has, I think we've got questions coming up. So.
If anybody's not clear, wants to talk, if I put up my email, if anybody wants to email, please, please do. Happy to phone people back. Sometimes in these things, people don't want to speak up and talk in public, and that's fine. If you want to go through something, if I'm not clear, please just email me, and I'll happy to chat, happy to talk to anybody.
Okay, so we'll just give another minute. If anyone's got any questions, you can either unmute and speak up, or you can put it in the chat box.
Just a quick question, this is Pravinder Garcha. There are patients who are sort of one or two mentioned looking at the capsule colonoscopy or the virtual capsule upper GI colonoscopy. Are these the things on the horizon? And
no, gosh, it's a really good question. No, colon capsules are just. Again, it's another piece of kit that we're just trying to work out what on earth it's useful for. The problem with colon capsules is that you need to take a ton of bowel prep. You've got to empty out the gut completely, and you've got to keep taking bowel prep as the colon capsule is going through. So what sort of patients would be able to take loads of bowel prep, be able to get to the toilet, all day long, squitting out everything, and yet wouldn't be fit for a colonoscopy? And you end up with a very sort of niche number of people, and we got asked if we would be part of a trial for colon capsules, and we as a pathway group, and we said no, don't be stupid, I can't think what that's useful for. And then we got told that wasn't the answer that was being looked for, and would we please take part in trial? And then we really couldn't get going with it because a capsule endoscope also has a huge reporting backlog. Reporting time. You're looking at sort of an hour of looking at images versus a 20-minute colonoscopy. It's going to be a really niche investigation, unless there may be things that none of us have thought of or I haven't thought of, but I don't think it's going to improve anything. There's also the environmental consideration of all these button batteries going down the toilet, if anybody cares about that. And then there's, but I think the next big move is probably going to be a replacement for FIT. There's talk of next generation FITs plus other biomarkers, which will be even more accurate. I think that's where we're going to end up going. The other thing we're trying to do is, very briefly, we did the studies. The nice fit was done on the population where a GP had already decided, I'm referring this patient with a 2-way pathway. So that clinical bit had been done, and then we did the fit and the test and compared results. What we now have, of course, is fit being used much more generally, which is good, as in a patient comes to see you with vague symptoms, and perhaps lots of amongst the battery of tests which are done, a fit is also requested. And then it comes back to you with a note saying the fit is 12, for instance, and this patient, according to NICE guidance, should be considered for referral, and then you end up referring. It's not clear at the moment that we're talking about the same population of people, so we're re-auditing this spring to try and work out what, if fit's still quite as good. I think our feeling is it probably is, just judging by the number of diagnoses that are coming through, but it's not proven, and I could probably come back to you next year with that data when I know a bit better.
Okay, so thank you very much, everyone, for attending. And thanks again, Alistair. We're now coming up to 2 o'clock. We would be really grateful if you could take a minute to complete the survey link, which is in the chat box. And yeah, I think we'll end it there. Thank you.
Bye, thanks.
Bye-bye.